at a problem that can only be characterized as homegrown, but through a lens that America all too rarely applies to itself. Okay, that is, I'm going to examine the causes, costs, and consequences of the opioid epidemic and propose responses from the premise that there is a human right to health. So first, let's start with some facts and figures about the epidemic. The rise in opioid overdose deaths in the United States can be outlined in 3 distinct waves. The first wave began with increased prescribing of opioids in the 1990s. Overdose deaths involving prescription opioids, which include both natural opioids such as morphine and semi-synthetic opioids like fentanyl and also methadone, have been increasing since at least 1999. The second wave began in 2010 with rapid increases in overdose deaths involving heroin. The third wave began in 2013 with significant increases in overdose deaths involving synthetic opioids, particularly those involving illicitly manufactured fentanyl. The illicitly manufactured fentanyl, or IMF, market continues to change and evolve, and IMF today is found in combination with heroin, counterfeit pills, and cocaine. That's the short history. How are we doing?
This has got to be a little distracting. I'm sorry. I just want to make sure. Is everybody, can you hear her?
Yes.
Okay.
All right, I'm going to briefly pause because next I want to put some numbers on the problem, and they really are aided by having the numbers up on the screen. Okay. And I have the flash drive, the USB drive, yep. And the very top file. Okay, awesome, thank you. That's me. So, as we were saying, here's my roadmap. What's the epidemic? Costs, consequences, and causes. And then looking at the epidemic through a rights-based approach to health. The 3 chapters you have seen. So now, some hard statistics. From 1999 to 2016, more than 630,000 people died from a drug overdose in the United States. As Professor Talsky told you just a moment ago, drug overdoses killed more than 70,000 Americans in 2017, a record, and about 66% of the drug overdose deaths in 2016 involved an opioid, so 2/3. Also in 2016, the number of those overdose deaths involving opioids was 5 times higher than in 1999, which gives you an idea of how rapidly the rate of opioid overdose deaths has been increasing. And on average, 115 Americans die every day from an opioid overdose. As you heard a moment ago, overdose deaths killed more people in 2016 than either deaths from firearms or car accidents. They are occurring at a pace faster than the HIV epidemic in its peak. And in 2015, and the reason that my dates are variable is because the CDC produces different statistics at different times when their reporting plays catch up. In 2015, over 97 million people took prescription painkillers, and 1 in 8 took painkillers that were not prescribed by a doctor. A local statistic for my hometown in Chicago alone, there were over 700 deaths due to opioid overdose in 2016, which is a 74% increase from the year before, and that increase was driven by a 600% increase in deaths due to illicit fentanyl, or IMF. How many prescriptions are circulating A CDC report found that in 2015, the amount of opioids prescribed was enough for every American to be literally medicated around the clock for 3 weeks. And they are prescribed at a higher rate in the United States than anywhere else in the world, more than a third higher than peer countries in second and third place in terms of rates of prescription, Canada and Germany. So since opioids come in many forms, I want to take a moment to focus specifically on prescription opioids. Since the 1990s, when the amount of opioids prescribed to patients began to grow, the number of overdose deaths from prescription opioids has also increased. And it's noteworthy that even as the amount of opioids prescribed and sold for pain has increased, the amount of pain that Americans report has not similarly changed. So it's not that we as a country are feeling worse, but rather we as a country are being treated differently for what we report to our healthcare providers. From 1999 to 2016, more than 20,000 people died in the United States from overdoses related to prescription opioids. In prescription opioids, deaths were 5 times higher in 2016 than they were in 1999. More than 40% of all U.S. opioid deaths in 2016 involved a prescription opioid, with more than 46 people dying daily from overdoses involving prescription opioids. And if you're curious, the most common drugs involved in prescription opioid overdose deaths were methadone, oxycodone, and OxyContin being one example of that, and hydrocodone, and an example of hydrocodone is Vicodin. A few more stats that I don't have a slide on, but just to paint a fuller picture, overdose deaths from prescription opioids were highest among people aged 25 to 54 years, so what we would think of as the prime of life. Overdose deaths from prescription opioids were higher among non-Hispanic whites and American Indian or Alaskan Natives compared to non-Hispanic Blacks and Hispanics. The rate of overdose deaths from prescription opioids among men was 6.2 per 100,000 people, and among women, 4.3 for every 100,000 people in 2016. And you may have heard that the opioid epidemic is focused on the eastern seaboard. That's true. The highest overdose death rates from prescription opioids were in West Virginia, Maryland, and Maine. Okay, the costs of the epidemic. I'm following my roadmap. The costs of the epidemic are almost impossible to quantify in their entirety. So the numbers a moment ago showed the impact in terms of loss of life. Lawsuits that are currently pending that were brought by state and local governments allege damages based on costs to those governments of ambulance services, emergency room expenses, and so forth. By way of just 2 examples, the state of New Jersey's complaint against Purdue Pharma estimates that since 2008, New Jersey's Medicaid vendors, workers' comp program, and employee and retiree health plans have paid more than $290 million for opioids, and that is in a relatively small state. The city of Tacoma, in its lawsuit against pharmaceutical manufacturers, indicated that the opioid crisis has increased the city's spending across healthcare, social services, emergency services, and public safety. And the city has had to implement a new tax to raise $10 million a year to fund opioid response efforts. So the costs are difficult to quantify in their entirety, but it's not impossible to estimate them when we look at units of local government, which is what the opioids lawsuits, which I'll be speaking more about, try to do. So another somewhat discrete cost of the epidemic is lost productivity and its impact on the economy. And there was a September 2018 report by the American Action Forum that estimated, first, that in 2015, over 2 million prime-aged individuals were not in the labor force due to opioids. Between 1999 and 2015, the decline in labor force participation cost the economy 27 billion work hours. And during that period, the reduction in work hours slowed the real annual economic growth rate by 0.6 percentage points, which doesn't seem like a whole lot, but that translates into $1.6 trillion in real output. And again, the largest negative economic effects in the United States occurred in West Virginia and also in Arkansas, where the prime-age labor force participation rate declined by 3.8 percentage points, and the real economic growth rate slowed by 1.7 percentage points. So we can quantify the cost of the epidemic in terms of how it is affecting our economy and our productivity. Now, other consequences of the epidemic are analogous to the aftermath of other devastating public health crises. For example, like polio, a scourge in America until the mid-20th century, opioid addiction can inflict lasting physical damage on its victims well after they are taking opioids, including the examples that you see on the slide before you. Just as insidious, not only for recovering addicts, but for their friends and families, as well as those who have lost a loved one to the epidemic, is the collective trauma of a great loss endured and a fear that opioids abuse will resume. So now we come to causes. How did we get here? As I said, this is a homegrown problem, and truthfully, a collective mea culpa is in order. First, the medical profession enables Americans' instant gratification approach to pain, including non-chronic pain that is not associated with a terminal illness, and have fallen short in counseling patients about potential for addictiveness. Second, efforts to prevent illegal opioids from entering the United States have been inefficient and frankly largely ineffective, with criminal law enforcement doing little to deter the narcotics business and also consumer demand. Heroin seizures and high-profile prosecutions, in fact, have encouraged traffickers to create more compact, potent drugs, including the deadly synthetic opioids, fentanyl and carfentanil. But there's more. Pharmaceutical companies that manufacture prescription opioids have long downplayed their addictiveness and efficacy in addressing chronic pain, as alleged in many of the currently pending lawsuits. Insurers, including Medicaid, have balked at covering treatment for opioids addiction or alternative treatments for chronic pain. Opioids may be cheap in the short term compared to other forms of treatment for pain, but certainly are exacting an expensive toll in the long term. And yet those same insurers have readily paid for prescription opioids. And so now I propose to take on the opioid epidemic with a rights-based approach to health. So first, what does that mean? Well, if you've taken Professor Batensky's International Human Rights Law course, you've doubtless talked about the meaning of a human right in the first instance. It's a right or an entitlement to which every individual, regardless of national origin or location in the world, is entitled. And so is there a right to a human right to health. We can easily think of other rights, civil and political rights, freedom of association, freedom of expression, including religious expression. Political rights include the right to participate in your government, the right to free and fair elections. A right to health would fall into the notion of social or economic rights. And a right to health sounds lovely, but a little vague. So, is there a universal right to health? The answer is it depends on whom you ask. And some folks have said yes. In 2002, the United Nations appointed a special rapporteur on the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. That right is reflected in the Universal Declaration of Human Rights, which states that everyone has a right to a standard of living adequate for the health and well-being of himself and of his family. And I might add, herself and her family. Standards of living are considered social determinants of health. If you don't have access to potable water, your health will be affected. If you don't have access to schooling for your children, that too translates into an indirect effect on your children's health. And it is those social determinants that are contemplated by the Universal Declaration when it states that everyone has a right to a standard of living adequate to health and well-being. And then finally and most explicitly, at the International Conference on Primary Healthcare organized by the United Nations in 1978, the parties issued the declaration that health is indeed a fundamental human right. However, the right to health is not universally recognized under the law, most notably here in the United States. And what's quoted up there is a case from the Second Circuit Court of Appeals, Flores versus Southern Peru Copper Corporation. In brief, the Southern Peru Copper Corporation had done mining in the Andes. The copper mining had released particles and pollutants into the air that allegedly sickened the entire town, endangering their rights, the complaint asserted, to health and life. This complaint was brought pursuant to the Alien Tort Claims Act, which provides a basis for federal jurisdiction, and the Second Circuit rejected it out of hand. Why? Because it is simply too vague. The Second Circuit said, what does a right to health even mean? How can we enforce a right that doesn't have clear limits or boundaries or bright lines? The rights to life and health are insufficiently definite to constitute rules of customary international law. The right to health is boundless and indeterminate and devoid of articulable standards and regulations, and utterly fails to specify what conduct would fall within or outside the law. Now, in those countries with newer constitutions than ours, that have a more robust jurisprudence recognizing social and economic rights, which the United States tends to habitually avoid, the right to health is considered a right of progressive realization. In other words, as I said before, it's not an all-encompassing right to health. That really would be impossible to implement and enforce. Rather, the right to the highest attainable standard of health is a right of progressive realization. And the ceiling that caps the highest attainable standard moves ever higher, thanks to science and technology. So here in the United States, we are blessed to have cutting-edge treatment. That highest attainable standard of health in the United States is as high as anywhere in the world. But we also have significant disparities in access to such treatment, which stems from our traditional approach to healthcare as dependent on employer-based insurance. But an epidemic of this proportion in the United States calls for collective action and action by the government in a way that a system of healthcare has never previously offered. And so in this, I'm reminded of a case that many regard as the iconic right to health decision, which is called the Minister of Health versus Treatment Action Campaign out of South Africa's Constitutional Court in 2002. And I'm going to take a few moments to discuss the facts of that case and what lessons we might learn to apply to America's opioid epidemic today. Okay, so the context of the Treatment Action Campaign case is the AIDS pandemic in South Africa. In South Africa, obviously a much smaller country than our own, we have 5.27 million people infected in 2007, and almost 18% of adults, again, in those prime years. The successor to President Nelson Mandela, Thabo Mbeki, has engaged in a form of what came to be known as AIDS denialism, asserting that the infection HIV does not cause full-blown AIDS, that antiretroviral drugs do not treat the disease but rather are fatally toxic, and more generally was involved in a somewhat nationalistic communications method for political purposes. So, the plaintiffs in the case were the Treatment Action Campaign, which is an NGO that is a national treatment advocacy group, along with a physicians organization and a children's rights NGO. The defendants are the Minister of Health for South Africa and the provincial health departments. The issue relates to an antiretroviral drug that was developed to prevent mother-to-child transmission of HIV. The drug was known as nevirapine. Nevirapine was highly effective, and the maker of nevirapine had offered to provide it to the country of South Africa, including the provincial health departments, and we can think of provinces like states, free of charge. That said, President Mbeki and the Minister of Health declared that the science was uncertain as to whether or not nevirapine, an antiretroviral, would be effective in stopping mother-to-child transmission, and that even though the pharmaceutical company was offering to make it nationwide free of charge, it would not permit that and rather would be conducting its own research on its efficacy. This at the height of the epidemic. The plaintiffs filed suit asserting that this violated the right to health articulated in the South African Constitution. And of course, it is the post-apartheid Constitution, and it does state that there is a right to health, but gives no details about when that right to health should be enforced. So the plaintiffs assert that the state's delays and refusal to make nevirapine available violates the South African Constitution. The defendants respond, no, our approach is reasonable. The comprehensive approach is too costly. Even though the pharmaceutical company was making nevirapine free of charge, they were referring to personnel costs. And their concerns about effectiveness are legitimate. What happened? South Africa's Constitutional Court found the state policy to be unreasonable. It found that the policy denies a potentially life-saving drug to children born to indigent mothers who were dependent on the state for health care. Now, that said, the court also acknowledged that it's impossible to give everyone access to any service immediately, and ordered that the state of South Africa must only act reasonably to provide access to the Constitution's rights on a progressive basis. So the right to health being a right of progressive realization. You can think of this as the Rome wasn't built in a day rule. And you can also imagine during this time in South Africa, the Treatment Action Campaign looking for the right test case to enforce the right to health. This is really it. This is the optimal test case. You have an epidemic of catastrophic proportions. You have a drug that has been shown to prevent mother-to-child transmission. And you have the manufacturer of that drug offering to provide it free of cost. So how is this analogous to America's opioid epidemic today? Compare the language from the South African Constitutional Court. The HIV pandemic in South Africa has been described as an incomprehensible calamity and the most important challenge facing South Africa since the birth of our new democracy and government's fight against this scourge as a top priority. It has claimed millions of lives, inflicting pain and grief, causing fear and uncertainty, and threatening the economy. These are not the words of alarmists, but are taken from a Department of Health publication in 2000 and a ministerial foreword to an earlier departmental publication. Similarly, in 2017, the U.S. Department of Health and Human Services declared the opioid epidemic to be a nationwide public health emergency. As you heard earlier, overdose deaths are higher than deaths from HIV, car crashes, or gun violence at their peaks. And both countries, that is to say South Africa in the 90s and the United States today, are in a state of crisis due to these profound epidemics. For that reason, there is no more appropriate time for a nation state to intervene. Now, it's true that hospitals, many medicines, and many other forms of treatment are expensive. And without a single-payer system in the United States to bear these costs, access to healthcare in America is primarily driven by the insurance markets. The good news, lest you thought this was going to be a solely depressing start to your December, the good news is that our response to the opioid epidemic can be efficient, impactful, and cost-effective, all in a way that maximizes our access to the highest attainable standard of health. So just as a multitude of factors caused America's opioids problem, a multitude of stakeholders must collaborate and coordinate to solve it effectively. Innovative approaches by these stakeholders have begun to take root, and where they are implemented, they work. What are some examples? To prevent addiction, changing prescribing practices works. It's self-evident that taking prescription opioids for longer periods of time or in higher dosages can increase the risk of addiction, also called opioid use disorder, as well as overdose and death. Patients and providers must discuss the risks of opioids, consider alternative therapies, and if prescribing opioids is appropriate, the provider should offer fewer prescriptions for fewer days and at lower dosages. Now, the overall opioid prescribing rate in the United States has been declining since 2012, but the amount of opioids it's measured in what's called MMEs, morphine milligram equivalents per person, is still around 3 times higher than it was in 1999. To save lives, naloxone works. Naloxone is the miracle drug for this epidemic, a medication that can save someone who has overdosed on opioids, even fentanyl, although fentanyl is so toxic it requires multiple doses of naloxone to reverse. Both federal and state health agencies have the ability to negotiate lower prices and expand access to naloxone, and also to provide encouragement, such as a public health education advertising campaign, to those pharmacies that are already offering it prescription-free in many states. Congress can also help by passing legislation to protect responders who administer naloxone from liability, a federal version of what in Illinois is called the 911 Good Samaritan law. And I don't actually know if Michigan has a Good Sam law, but the idea is that somebody who administers naloxone to save the life of an individual who is overdosed is essentially shielded from liability, can't be charged criminally with battery, can't be, and also can't be sued civilly. Education about addiction also works toward both prevention and treatment. Misunderstanding of opioids addiction shrouds nearly every effort to reduce its toll. A 2015 study by the National Institute on Drug Abuse found that life skills training for 7th graders helped them avoid misusing prescription opioids throughout their teenage years. A nationwide health education campaign about all aspects of the epidemic, like that used by the Federal Centers for Disease Control and Prevention to fight AIDS in the 1980s, when the agency sent a brochure, Understanding AIDS, to every residential mailing address in the United States to dispel myths and help Americans seeking treatment, should commence immediately. Implementing alternative forms of pain management works. American physicians, as I mentioned a moment ago, prescribe opioids for pain management at a far higher rate than in any other nation. Addiction to prescription opioids can lead to the use of heroin and fentanyl when prescriptions run out. Healthcare providers and medical students report concerns on insufficient training in pain management. The CDC now offers recommendations that may help to improve prescribing practices and ensure that all patients receive safer, more effective pain treatment. And CDC also offers continuing education for healthcare providers. To treat addiction, rehab works. Nearly 300 law enforcement agencies in 31 states now participate in the Police-Assisted Addiction and Recovery Initiative, which offers treatment for drug users who ask authorities for help. And this was an approach inspired by a program in Gloucester, Massachusetts, a town that was particularly hard hit by the epidemic. Officers work the phones to get addicts into treatment and recovery networks in an effort that costs less and promises more lasting results than repeatedly arresting them. At the same time, on the federal level, the Drug Enforcement Agency has implemented a new approach to illegal opioids while not abandoning the enforcement approach that it has traditionally used and that, in my opinion, has been ineffective in stemming the epidemic. The new approach is called DEA 360, and it includes not only criminal prosecutions of trafficking organizations, but also partnering with community organizations and schools, as well as pharmaceutical manufacturers, practitioners, and pharmacists. More specifically, medication-assisted treatment works. One of the most effective methods of treating drug addiction is through continuing medication therapies like methadone, naltrexone, and buprenorphine. These medications help guard against relapse and also help people return to work and rebuild their lives. Yet fewer than a third of conventional drug treatment centers in the United States take this approach. Instead, agencies place individuals who cannot afford to pay in ineffective short-term programs with no follow-up. Some halfway houses and work programs reject people on methadone or other medication-assisted treatments in a not-in-my-backyard attitude. People struggling with addiction can be vulnerable to exorbitant so-called detox rehab stays, as can members of their family who are often footing the bill. Treating associated conditions works. Up to 70% of people with substance abuse problems also suffer from depression, post-traumatic stress, or other mental health disorders. This makes them more vulnerable to abuse and to relapse. There was a federal law passed in 2008 called the Mental Health Parity and Addiction Equity Act, and this actually prohibits insurers that cover behavioral health from providing less favorable benefit packages for mental health and addiction treatments than they offer for other medical therapies or surgery. Nevertheless, some insurers continue to defy this law, imposing arbitrary treatment limits or onerous authorization requirements. Now, finally, and interestingly, in light of the Affordable Care Act, also known as Obamacare, it appears that Medicaid expansion has tremendous potential to work at the community level to address the opioid epidemic. So you may recall, and if you took the National Federation of Independent Business versus Sebelius, if you read that opinion in either a tax class or a Supreme Court jurisprudence class, you may recall that the Affordable Care Act, or Obamacare, originally mandated that states significantly expand access to Medicaid. The Sebelius case challenged a number of the Affordable Care Act's provision, including the mandatory Medicaid expansion. And the Supreme Court held in the Sebelius case that the mandatory expansion of Medicaid was not a valid exercise of Congress's spending power, as it would coerce states to either accept the expansion or risk losing existing Medicaid funding. And so it became optional. It is up to the states under the Affordable Care Act to expand Medicaid eligibility or not. And to date, that's a screenshot, so it's a little distracting. To date, 36 states and the District of Columbia have voluntarily expanded Medicaid under the Affordable Care Act. 14 have not. The Medicaid expansion enables the state to allow state-funded treatment in a way where those funds simply would not otherwise exist. And so I have a little text box up there, which is a city that was hit especially hard by the epidemic, Dayton, Ohio. And Governor John Kasich did expand Medicaid in the state of Ohio. Dayton had one of the highest opioid overdose death rates in the nation in 2017, just last year, and the worst in the entire state of Ohio. The county had 548 overdose deaths by last November 30th. So far this year, there have been only 250, a 54% decline. And the city gives much of the credit to the governor's decision to expand Medicaid in 2015. According to the mayor of Dayton, that move gave nearly 700,000 low-income adults access to free addiction and mental health treatment. And in Dayton alone, that's resulted in 12 new treatment providers in the last year, residential programs, and outpatient clinics that dispense methadone, buprenorphine, and naltrexone, the 3 medications approved by the FDA to treat opioid addiction, and other programming. So that was a summary of what works. What's this picture of these gentlemen have anything to do with what I've been talking about? Well, this picture is going to illustrate the final point, which is lock them up and throw the key. Lock them up and throw away the key does not work. Now, everything that I just described, like most things in life, is not free. Federal funding is needed for most of them. But this would not be the first time that Congress and a president have acted decisively to appropriate funds to address addiction. And now it becomes personal. In the last week of 1963, my father, Ted Sorensen, who's the serious-looking young man with the glasses seated at the table, met with President Lyndon Johnson on the left of course, late into the night at his Texas ranch to decide what provisions of President John F. Kennedy's unfinished agenda to include in Johnson's upcoming State of the Union address. Last on the list was a provision for expanded federal jurisdiction over illegal drugs, which provided not only for federal criminal law enforcement, but also for expanded rehabilitation and treatment program. As my father told the story, Johnson angrily brushed aside the suggestion. Drugs? I don't want anything to do with them. Just lock them up and throw away the key. The meeting ended, and my father deleted that portion of the speech, which famously announced the war on poverty, but kept the drug provision in Johnson's legislative program. This led to controlled substance and drug addiction reform that passed with bipartisan support in Congress. Despite Johnson's dismissal of my father's proposal of treatment and rehabilitation, he extolled those ideas when he signed the Narcotic Addict Rehabilitation Act in 1966, describing it as a, quote, pioneering measure that recognizes that treating addicts as criminals neither curtails addiction nor prevents crime. But during the 1980s, the federal war on drugs gathered strength and brought a renewal in the punitive approach to drug abuse. Although the 1986 and 1988 Anti-Drug Abuse Acts did increase federal funding for treatment and rehabilitation, these statutes also introduced to federal law a system of mandatory minimum prison sentences for controlled substances, including non-prescription opioids. Finally, and appropriately, I must mention litigation, which has the potential to work. For 3 long years, the city of Chicago and 2 counties in California were the only government entities that had filed civil suits against prescription opioid manufacturers, alleging deceptive marketing practices regarding both the addictiveness of their drugs and their efficacy in long-term chronic pain management. After Chicago and the 2 California counties survived multiple motions to dismiss and were proceeding to discovery against the pharmaceutical manufacturers, the New York Attorney General announced a bipartisan coalition of 41 attorneys general from across the country that had coordinated subpoenas of information and documents from the manufacturers and distributors of prescription opioid drugs, part of a multi-state investigation into whether the companies engaged in any unlawful practices in the marketing and distribution of prescription opioids. At the same time, a majority of local government plaintiffs in pending federal opioid litigation, including the Chicago case that I just mentioned, have now been consolidated into an MDL, a multi-district litigation for a consolidated docket in the national prescription opiate litigation currently proceeding in Ohio. The lawsuits seek compensatory and punitive damage for the millions of dollars that the counties spend each year to combat drug-related crimes, as well as the so-called public nuisance created by the pharmaceutical manufacturers' allegedly deceptive marketing campaigns. The complaints also allege millions of dollars spent each year for the healthcare costs incurred by prescription opioid dependency. What would a resolution in favor of the local governments mean? It could include a court order prohibiting opioid manufacturers from deceptive marketing practices and mandating increased warnings about the addictive qualities of opioids. A favorable settlement or verdict, and I think it is likely to settle at some time next year, could also mean damages that would fund prevention, harm reduction, and recovery policies. To be sure, in case you don't know this from having spent a year or 2 or 3 or a semester in law school, litigation is both expensive and inefficient. Our justice system is not preventive, it is remedial, designed to remedy a wrong after the fact. But it can also be a vital backstop in crises such as the opioid epidemic, in which both Congress and the President have failed to fund meaningful prevention and treatment. The opioid epidemic will be stemmed by a web of proven interventions, some of which I've described. They're worthwhile, but they are not costless. So where other branches cannot or will not act, state and local governments must seek relief for their citizens through the justice system. We'll close with a founder. In Federalist Paper number 78, Alexander Hamilton described the judiciary as having, quote, neither force nor will, but merely judgment. For a nation in the grip of an epidemic toward which Congress and the President have exercised insufficient force and inadequate will, judgment can bring meaningful relief to devastated communities, albeit years too late. All of these initiatives and more must be implemented in a comprehensive approach involving resources, cooperation, and coordination across disciplines and across the country. A multifaceted strategy is essential to crest the arc of the opioids epidemic. We have no time to waste. Thank you very much for having me today.
Any questions?
Yes.
Are there any consequences for doctors or hospitals that prescribe inappropriately?
Yes, there are. So there are so-called pill mill cases. It is actually a violation of criminal law to be writing prescriptions without a basis, not to mention the risk of losing one's medical license. The pill mill cases are one way of addressing prescription opioids, but wouldn't be a cure-all. As you can imagine, there are many prescribers who legitimately prescribe an opioid for a patient who then develops a disorder, and that provider believes that they're acting in the best interest of the patient. But yes, there is a federal criminal law remedy. Yes.
So you talked about states that did expand Medicaid and how it's helped the crisis, but have you seen any specific programs or nonprofit type of work that has really tackled the crisis in those states that didn't expand Medicaid?
Yeah. So the issue is that the money's got to come from somewhere, right? And it can come privately. It can be raised by nonprofits, with that nonprofit status. It can come from other sources of state funding, but the federal government has a lot more money, right? And so at the end of the day, those efforts are not nothing, but they're simply not going to have enough resources to bridge the gap that Medicaid expansion can do. Yes.
So you had mentioned with what works, DEA 360 and their community outreach. I have kind of a two-part question on this.
Yeah.
So I've seen some theories where they've shown that addiction is lowered merely by having a stronger community.
Yeah.
And I was wondering if you've seen how effective these community outreach programs have been, and then also if there's an added challenge in today's world where there's more sprawling developments and general disconnection, especially in the United States.
So, one thing that I didn't talk about today, which is appears to be associated with the opioid epidemic, is the increased suicide rate in the same cohort, the same demographic cohort that is most affected by opioids abuse. It's America's life expectancy due not only to the overdoses, but also to the increase in suicide, which has taken place at the same time in the U.S. that the opioid epidemic has actually resulted in a lowering of our average life expectancy here in the United States. To get to your point about community, the suicide rate appears not to be driven by addiction alone, but by what the Nobel Prize-winning economist Angus Deaton, who first wrote about this, called deaths of despair. And so it may be opioid abuse in a community that seems to lack prospects, that seems to lack support, whether it's a social safety net from friends and family, or whether it is a social safety net provided by community-based organizations. And so I think that DEA 360 is a belated but really worthwhile initiative, because you're bringing a federal agency that knows the controlled substances with considerable resources to a community-based approach. So they're working with social workers, they're working with healthcare providers, they're working with community organizers. And that gives a federal agency credibility that otherwise, you know, by simply looking at them as the feds, they lack. Again, it is somewhat subject to policy and politics priorities. Those priorities shift from one attorney general to another, from one administration to another, and even from one U.S. attorney to another. So if a given U.S. attorney says, I believe our job is enforcing federal criminal law, and that's really where we're gonna focus, then she or he can pull back from those community initiatives. But DEA piloted DEA 360 in 3 cities, I think Milwaukee, Pittsburgh, and I forget the third, and it was viewed as a great success. So they've now significantly expanded DEA 360 across the US. Yes?
I work in substance abuse prevention, and so I've studied addiction disorders a little bit, and I understand that treatment of opioid addiction can be a little bit different than our approaches to treatments of other addiction disorders, because often people who are withdrawing from opiates have a tremendous amount of actual physical pain. And so while community building is important, there's also the underlying question of how do we manage pain for those patients?
Sure.
Because there's the neuropathic pain from the medication itself and withdrawal, and then there's the breakthrough pain potentially from whatever condition they went on the opiate to treat in the first place. And so I know one barrier that I've seen is lack of coverage by insurance companies for alternative forms of pain treatment. And so I wonder if you've seen any kind of push or pressure being put on private insurance companies to offer more coverage for things like acupuncture and yoga and alternative health treatment.
Yeah, it's a great question. So, you know, I referred briefly to medication-assisted treatment being highly effective. And by medication-assisted treatment, I mean not only methadone, right, and other opiates to address cravings and withdrawal, but also those associated pain conditions. And yes, it really varies from one insurer to the next. Biofeedback, physical therapy, occupational therapy, massage, mind-body treatments, all have been proven to be very effective in managing certain types of pain, and indeed actually more effective than opioids in certain situations. And I would say again that's distinct from palliative or end-of-life pain, where opioids are actually highly effective. When you think if anybody has had a loved one in the ICU and you've seen the relief that for example morphine can bring. Those programs have to be regarded by insurance companies as an investment, and it's an investment that reaps dividends because they are expensive, but they're a lot cheaper than what we're all facing now as a country with the levels of opioid abuse and overdose. And so insurers will stop physical therapy after 8 weeks, but they'll stop medication-assisted, but they'll prescribe an opioid for 12 weeks, for example. Yes?
For the medication assisted, I mean, I know of stories of people being prescribed that for years, Suboxone or methadone.
Yeah.
So I don't really understand how that's a solution. It's just a legalized opioid that makes them I mean, depending on the person, it may or may not make them more, able to function in society.
Yeah, that's right. So I think that an ER physician would tell you, my goal is to save a life and get the person into treatment. All right. So that's the first step. You save a life, and for that you need naloxone. You get the person into treatment, and then the steps beyond that are you enable them to resume their life, their family, to be gainfully employed. Beyond that, it becomes highly individualized. Right? To continue on methadone for years may be enabling. It may be necessary, and it's really hard to say. It's hard for me to normatively say what's right or wrong. I don't think it's enabling an epidemic. I think it's enabling at least a relative degree of functionality. But the issue is very controversial in communities that house methadone clinics, where people are,
I mean, sorry, just to push back a little bit, you could also just decriminalize heroin and the opioids instead of having the pharmaceutical companies create a different one that's prescribable. And then, I don't know, so some people function very well on heroin. It's going back and forth from heroin. I don't know, I just don't see the.
So I try to constrain my talks within the parameters of political realities, and other countries have decriminalized controlled substances. It's pretty much a non-starter here in the United States at the federal level.
I'm more on the side that I don't think medical assisted is an appropriate or successful remedy.
Do you think that decriminalization would be a more effective way of addressing
with the
it?
political, living in political realities. In Holland, it seems to not have been so difficult. But I find in reality here, when people are prescribed methadone for a very long time, and it's not free, and Medicare, if for any reason you can't, you're talking about $350, $400, $500 a month. It just traps people in another cycle that is just as much of a problem, and it's not a solution.
Yeah, I agree. I don't think that there has to be an end game, right? It doesn't seem like a sustainable or cost-effective solution for a lifelong form of management. It's just not like diabetes, right?
Yeah, it just seems like the easy way out, a solution that's the easy way out. I mean, if you have to choose where you're gonna focus your efforts, there's so many other solutions that seem better. Yeah.
Well, and again, because we don't, unlimited resources are not an option, then choices are necessary. Yeah.
I was just gonna respond to that, and then I do have one additional question.
Yeah.
I think you hit the nail on the head with the fact that pharmaceutical companies did have a say and a benefit in Suboxone methadone clinics. And I worked for a neurologist this past summer, and I think the research and the opinion kind of rising out of the medical community is that it is completely inappropriate for long-term treatment, and that where it's most effective is with people with really critical conditions related to their heroin addiction. Heroin today is so potent and it's so risky because of fentanyl that it's most helpful for helping in the first week those who are withdrawing from potent heroin addiction and making it through the withdrawal symptoms in order to, I guess, prevent reinstatement of the addiction to heroin. So, and that's really the only encouragement I'm seeing in the medical community for the use of Suboxone methadone these days. I do have one question about we were talking about the different treatment methods or prevention methods that are working, and I wondered if you've looked at the results coming out of any of the countries or states. I know Canada has approved it, and there are certain states that are exploring it with legalizing approved consumption sites or clean needle exchanges. I wondered if you have any insight into those.
Yeah, so there is a lot of research that shows that they are safer and lead to actually both a reduction not only in overdose deaths but in addiction and abuse. same answer that I gave to this woman. I omitted that from my talk because it is highly controversial and currently a political non-starter in the US, but it is an absolutely evidence-based approach. Yeah, safe consumption sites. If the position of the Department of Justice is that it is a violation of federal law. If they had not overtly taken that position and said that they were actually going to make it a priority to enforce that, I'm certain that local governments in our country would be experimenting with it right now. Well, thank you guys. Is there?
Yes, thank you very much for attending. Good luck.